So really, the scope of this talk is just to go over some of the mechanical support devices that are available for this high-risk PCI, whether it's chip, slip, whatever you want to call this procedures. And I think it starts by what is the rationale for this. And the rationale is an inability of a high-risk patient, like the ones that have been shown before, to be able to maintain or tolerate the hemodynamic consequences of dysrhythmia, transient ischemia, reperfusion, or atherogenic material going and having the no reflow phenomena, as it was shown yesterday in the case with Dr. Colombo. Again, these are high-risk patients, and what we're trying to do is try to minimize these issues. Now, what it comes down is to really what is the definition of that high-risk patient, and I think every one of you guys will have to do that in your practice. But in general, this definition is based on a clinical criteria and an anatomic criteria and a hemodynamic criteria. So you have to look at the patient, you have to look at the lesion that you're going to be dealing with, and you have to look at what the hemodynamics are. So obviously, low ejection fraction patients with a complex PCI, whether it's left main bifurcation, multi-vessel, high syntax scores, and or patients with hemodynamic instability, low cardiac output, a high wedge, or pulmonary hypertension. So when you start combining more of this characteristics, then this patient becomes higher risk. What are the benefits of mechanical support? Basically, you're augmenting mean arterial pressure. The case that was shown yesterday where when Dr. Colombo, you saw that during balloon occlusion, the pressure went down, but it was maintained. And then also you have maintaining end organ perfusion, so you maintain kidney perfusion, and you are optimizing myocardial perfusion by lowering the end diastolic pressures, especially if you're using a device that unloads the left ventricle. And by unloading the left ventricle, you're minimizing the oxygen demand. So really the goals are two main goals. One is to maintain hemodynamics, and the other one is to facilitate the completeness of the treatment. So one thing that has been shown as you use some of these mechanical devices, you can do more complete revascularization and target more vessels to have a more complete result. So what are the options? The intra-aortic balloon pump would be the more basic one, and as you move to other devices, then you go into the Impella, the PHP, and then tandem heart and the ECMO, and I'll go over them and what the spectrum and when you can use one or the other. So again, the difference between these devices are here, and there are many tables that show, but just starting with the intra-aortic balloon, basically you have a device that everyone is very familiar with it. It's easy to place, but really the cardiac output augmentation that you get is only around half a liter. There's no major left ventricular end diastolic unloading, and the myocardial oxygen demand, you don't change it too much. So it's very basic. There have been a few trials done in cardiogenic shock to see if the balloon compared to either no balloon or other devices have been done. And these are the trials. There's a shock, the BCIS, and the CRIS. And overall, even though it's the most commonly used device, when you look at mechanical support on over 230,000 patients, 70% of those procedures were using a balloon whenever something was used. The reality is that there's no data showing that there's significant improvement in survival using the balloon pump, whether it's in the shock trial, the shock 2 trial. None of them have shown any significant benefit in emergency revascularization. So in summary, in terms of the intra-aortic balloon, there's no clear data supporting the routine usage of the intra-aortic balloon pump. It has limited cardiac output augmentation. It has limited left ventricular unloading and decreasing myocardial oxygen. And therefore, when you look at the guidelines, you have a class 2A indication for patients that become hemodynamically stable, and the routine usage of the intra-aortic balloon with cardiogenic shock is not recommended. In fact, it's a class 3 indication. Advanced device, the Impella, which has just got approval in India. This device gives you more support, anywhere between 1.5 liters to actually 5 liters, depending on the device that you use. You have unloading of the left ventricle, decreasing of myocardial oxygen demand, and really this is kind of the more used device in the modern era. And the Impella CP, which is their newer device is probably the most commonly used. As you know, there's a 2.5, and now when the CP came into the market, which has the same 14 French access, then as you get 3.5 to 4 liters of support, this becomes a little bit more versatile. There's a 5.0, but usually that needs a cut down and usually surgical insertion. And they have an RP for support of the right ventricle. But the Impella is more versatile. It increases flow, it increases mean arterial pressure, and it decreases left ventricular and diastolic pressures and in diastolic volume, which results in increase in cardiac power output, which helps for end organ perfusion, increases oxygen supply, and decreases oxygen demand. So you get all benefits from support. This is an example of a case, and this is what we saw yesterday, that if you have the Impella, so on the lower part you have no Impella support, and you are able to maintain the pressure depending on the balloon inflation and the time. When you are inflating for 30 seconds, 40 seconds, then obviously the decrease in blood pressure is significant. With the Impella, you're able to maintain that pressure. There have been multiple studies looking at the benefits of Impella, and these are some of the studies, Protect 1, the ISAR shock, and then the more recent ones, Protect 2 and Recover. But basically, when you combine those studies, and that was a combination of either comparing to something which usually was the intra-aortic balloon or no other support, the summary is as follows. With protected PCI, when you look at the real world, what's Impella being used, around 50%, and then around 35% is for cardiogenic shock. So kind of a mix of half and half. This is the same that I showed before. There's improvement in ejection fraction, and then also there has been shown to have some cost effectiveness depending on the markets. And therefore, based on all these studies, there's a expert consensus study, and the guidelines are here where you have PCI and cardiogenic shock, a class 1 indication, and you can see there what the more recent ones are. So from the Impella standpoint, you know, the benefits is technically it's easy, has the clinical and the hemodynamic support, and has some data to show the improvement. You have other options, like I mentioned, a 2.5 and a 5.0. The 5.0 usually is an axillary, and then you can also do a bipella where you put basically 2 devices for biventricular support. There's a small study showing that there's some benefits on biventricular support. A similar device is the HeartMate PHP. The PHP is Thoratec. There's a clinical trial in the US that was started, and basically it's a similar device. And what it has, it goes through a 14 sheath, and then you take the sheath back, and then this becomes a 24 French. So you end up with the impeller in the similar position that appears to have less movement than the Impella, and it appears because of the way the channels are made within the impeller that perhaps will have less hemolysis. However, the trial in the US was stopped, so if you go to the website, it'll tell you that it's been stopped. From what I hear, it's going to be restarted in the next couple of months. And basically, this is just a little pump that you put in the descending aorta. It can give you a 30% augmentation on cardiac, and you can just leave it in the descending aorta. And there's some studies ongoing now with this device. There's not commercially available, but I think there's some trials. So you'll see more of these pumps where you don't have to go across the aortic valve. You can use them for support. So it gives you more than a balloon, but less than an Impella, or something like a tandem heart, which would be your next level. The advantage of the tandem heart is that you have more configuration, so you can do veno-arterial, RA to PA, LA to FA, and then the only issues you have to, this is a transseptal approach, it's a 21 French cannula, so there are issues with transseptal, and you have to have versatility with that. As far as trials, there are not a lot of trials that are being looking at that, and the tandem per chip is something that in most places is not used unless you really think that the patient is going to need a lot of support and is going to need ECMO later on. Because then you can convert and you can put an oxygenator on the device if you want to, and obviously ECMO would be your final support, where you can basically, usually these are patients who were completely crashed, cardiogenic shock, you put them on ECMO, and then you go and do a PCI because the patient is not a candidate for surgery. So when you look at all your options, you basically have a balloon pump, you have ECMO, you tandem heart, Impella, RCP, or the HP. And basically, if you want to unload the ventricle, you either need a tandem heart, Impella, or ECMO. Balloon pump doesn't give you a lot of support. And the only other thing I just want to go over is over the contraindications and complications. So for the intra-aortic balloon, as you guys know, moderate to severe aortic insufficiency and peripheral vascular disease. The Impella, if you have aortic valve issues with aortic stenosis, there may be a contraindication.